Hello, this is Thomas Pearson, and this is my Westchester University Nursing 708 Quality Improvement Project Overview. Thanks for taking the time to listen. My Quality Improvement Project is concerned with the elimination of hypothermia in trauma patients transferred emergently to the operating room. In a Level 1 trauma center, some seriously injured patients will be transferred emergently or urgently to the operating room for surgical intervention. Some examples include serious internal bleeding, major head injury or intracranial bleeding, and penetrating injuries such as a gunshot wound. Preoperative nurses in the OR have reported some patients arriving hypothermic, measured as a core temperature below 36 degrees Celsius. At present, these reports remain anecdotal, without good data to establish the incidence of the problem. However, there is no safe level of hypothermia in trauma patients delivered to the operating room for emergency surgery, and the target rate for incidence should be 0. Let's speak for a moment of other projects with a similar focus. Beadle et al. Performed a QI project to implement a clinical practice guideline to reduce unplanned perioperative hypothermia in children. They state that children are at an increased risk of hypothermia because of physiological and physical differences from adults. Factors they examined included training, equipment, procedures, and the environment of care. They found good results in reducing unplanned perioperative hypothermia in children when a consistent clinical practice guideline was followed. Billiter et al. Studied 2,139 patients undergoing elective colorectal surgery and found a relationship between perioperative hypothermia and complications including wound infections and sepsis. Interestingly, they excluded trauma patients, allowing for permissive hypothermia, which is not a commonly accepted treatment modality in injured children. Rogers, Segaff, and Zakowski performed a QI project in burn patients and found hypothermia could be eliminated with pre-warming of the patient and intraoperative measures to maintain normothermia. For this project, the target population is children treated in the emergency department trauma bay as either a trauma alert or trauma code, the highest trauma team activation levels, who are transferred directly to the OR without floor or ICU admission first. Over 90% will arrive to the trauma bay via EMS by either ground or helicopter ambulance. Let's see what the literature says on the subject. Reitmeyer and Singh-Bartle defined hypothermia as a core body temperature under 36 degrees Celsius. Riley and Andrzejewski wrote that pre-existing hypothermia is exacerbated by general anesthesia, and that consequences of perioperative hypothermia include surgical site infections, altered drug metabolism, and coagulopathies. In a study by McCarty et al. That included over 414,000 pediatric trauma patients, they found that hypothermia is an independent risk factor and a significant prognostic indicator associated with increased mortality, increased rate of endotracheal intubation, and an increased need for blood transfusion. Rose and Newman wrote that poor quality transfer of information during perioperative handoffs results in significant errors, including scenarios such as transfer of a patient with unrecognized hypothermia. Campbell, Alderson, Smith, and Wardig, in a Cochrane review, wrote that warming intravenous and irrigation solutions, along with other perioperative measures to control heat loss, reduced hypothermic incidence and their sequelae. Collins, Budds, Rains, and Hooper wrote that risk factors for perioperative hypothermia are poorly understood and need to be defined in order to prevent it. Jacqueline Fawcett presents a unique view when she argued that nursing quality improvement projects, when published, infrequently cite a theoretical or conceptual theory, and when they do, it most often is a QI or change theory that is cited. Fawcett says that nursing QI projects should have a nursing conceptual model rather than change theory as the basis for the project. I wondered, is this a step forward? Is Fawcett's insistence on using nursing theory rooted in the past, in tradition and academia rather than practice? Under nursing theory, in Fawcett's own words, the conceptual phase of a nursing quality improvement project development is relatively abstract and general, and should be nursing discipline specific. Does this eliminate the nurse's involvement in multidisciplinary projects? Is a nursing theory model applicable to physicians, clerics, aides, pre-hospital personnel, and the myriad ancillary and support staff that directly affect the patient experience that have no nursing knowledge, yet will impact any quality improvement effort? In clarification, Fawcett stated that when nursing theory is combined with sound models of quality improvement or change theory, both relevance to the nursing profession and sound methodologies for interdisciplinary implementation can be simultaneously achieved. I have chosen the Six Sigma process improvement model. Six Sigma consists of 5 separate steps. First, to define the problem. Next, to identify, measure, and implement improvements. Next, analyze the process, define factors of influence. What is it that we need to improve? Is it measurable? Finally, to control, implement, and sustain the improvements. The key process through all of this is the use of data to make change. The goal of this project is to reduce the incidence of trauma patients transferred to pre-op holding with a core body temperature less than 36 degrees Celsius. This will be a Six Sigma QI project. The timeline will include forming under the Nursing Research Council, performing retrospective review to determine the number of previous cases, reviewing the current process and identifying performance changes, implementing those changes, then collecting data for 3 to 5 months or until a sufficient number of cases are evaluated. Some internal threats include project staff who experience sudden schedule changes, who have multiple other projects and priorities to juggle. Incomplete documentation may be turned in. I'm expecting a small number of patients, perhaps as few as 6 per year, and also IRB approval will be needed. External threats to validity also exist. For instance, under process, temperature readings may not be recorded due to computer failure, or the process may become burdensome and be overshadowed by emergency actions and then forgotten. Personnel may be new, unsure of policy, or they may not follow their assigned roles on the trauma team. Equipment may malfunction or be unavailable, such as a broken or misplaced thermometer. EMS patients may arrive hypothermic due to environmental exposure. To implement the project, an interdisciplinary team will be formed, consisting of trauma nurses, techs, management, OR nurses, and trauma surgeons, formed in cooperation with the Nursing Research Council. The primary outcome will be elimination of unplanned, unrecognized hypothermia in trauma patients within 6 months. An opportunity for risk adjustment is to exclude some EMS patients. Patients arriving via EMS who had a significant cold exposure, such as those found unresponsive outside in winter or submerged in cold water, and who could not safely be rewarmed prior to the need for emergency surgery, will be excluded from the project sample. Retrospective data can be pulled from the National Trauma Data Bank, NTDB, and identify trauma alerts and trauma codes that were admitted to the OR prior to admission to an inpatient bed. This NTDB data is already collected by the trauma registrar and is easy to access. Once identified, each patient record will be individually referenced in Epic, and temperature data will be entered into an Excel spreadsheet. Upon completion, an anonymous code will be used for each patient to protect their identity. Each record with a full documentation of temperature readings will be analyzed, and any patients delivered to the OR with a core temp under 36 degrees Celsius will be further analyzed using descriptive statistics. An Excel spreadsheet has been created and will be used for descriptive statistical analysis. A screen capture of the example Excel tool is seen here and includes demographic information as well as dwell times in the trauma bay and pre-op areas. When successful, this project will decrease the risk of serious complications for trauma patients admitted emergently to the operating room.